What is decompensated cirrhosis, and why do some patients recover from it while others don't?
Cirrhosis is a condition that can be completely silent until it decompensates, which means when a patient starts to feel symptoms of the disease or exhibit signs that their doctor can pick up. While some patients recover from decompensation while others don't, even if they receive the same treatment, remains unclear.
What set patients who do not recover apart? How can we increase the odds of recovery? This is where the Decision Project comes in, a collaboration of experts from 21 European partner institutions, scientists, doctors, and patient advocates, all on a mission to improve our ability to predict and treat decompensation.
The first step in Decision is to predict how a patient with decompensated cirrhosis will react to standard medical therapy. We do this by comparing patients who recovered from those who did not, considering factors like gene expression, medical history, and blood markers. Using this information, we want to focus on patients with a bad prognosis and develop for them new therapies. Indeed, Decision's ultimate goal is to improve the recovery of patients with decompensated cirrhosis.
Various experts are working towards this goal in different ways. The project is divided in 7 work packages, all with their own goals.
I work on a stratification method that clusters patients with complex diseases into subgroups using clinical data. This can help us to better understand the disease and improve patient management. We tested our method in patients with acutely decompensated cirrhosis and followed them over time. In addition, we validated our method in an independent group of patients. We have then designed a web tool that predicts in which group a patient fits to be used by clinicians and researchers. In addition, I've been working on single-cell data of patients with acutely decompensated cirrhosis, trying to better understand the immune changes involved in the progression of cirrhosis and trying to find gene markers of severity at the early stages of the disease. I believe that the use of computer science in biology for the analysis of big datasets empowers clinicians and researchers by, for example, providing data-driven knowledge of disease mechanisms. We collaborate closely through regular meetings, data sharing, and finding ways to translate our results into the clinic.
To go from theory and models to improving the patient's healthcare, it is important that the researchers and doctors working on the different parts of Decision come together and share their results and ideas. This happens during the general annual meetings. Here we also talk about what's next, the COMBAT trial.
Individuals with advanced decompensated cirrhosis present several and recurrent complications of the disease, which often require urgent admissions to the hospital. Therefore, it will be extremely important to have therapies able to prevent complications and reduce the hospitalizations, thus improving the outcome of these patients and their quality of life. The COMBAT trial has been designed to address this unmet need. Patients at discharge from the hospital will be divided into 2 groups. The first group will receive the standard medical treatment, which is the best treatment currently available for decompensated cirrhosis, while the second group will receive the standard medical treatment plus enoxaparin and albumin. These 2 drugs are used currently to treat some specific complications in patients with decompensated cirrhosis, but they have never been tested in combination and with this objective. If the results of the study will be positive, the COMBAT trial will be an important step forward to a better care of decompensated cirrhosis.
I'm in charge of work package 6, which is health economics. Health economics means that we will look at the costs associated with the health gains from combinatorial therapy based upon data from the COMBAT trial. Then, because the duration of COMBAT is rather short, we will need to extrapolate the results over a longer time period, and to do that we will use the survival data from the PREDICT cohort. So our main partner is Work Package 5 because of the COMBAT trial, and we have been involved in the trial protocol. We also work with data from the PREDICT cohort to extrapolate the trial data, and we work with the communication and dissemination work package as well.
Patients' voices are represented in the COMBAT trial in different ways. Firstly, ELPA Representica patient community actively participates in the planning and execution of the trial, making sure that patients' perspectives and needs are considered. Secondly, patients themselves are encouraged to be involved in the trial design and can directly provide an input. Outcomes and feedbacks from patients are collected and used to adjust the trial according to real-life experiences. Lastly, the involvement of patient representatives helps to maintain an ongoing dialogue and ensures that the trial stays focused on the improvements of patient care and the outcome of decompensated cirrhosis patients. Patient representatives also ensure the transparency and help to build the trust in medical research.
Stay up to date and follow us on X and LinkedIn. Subscribe to the newsletter and go to the website for more information.